Welcome everyone to our SEALA Speaks. I hope everyone can hear me. Looks like everybody's muted. I'm Greg Pokrywka, current president of SEALA, and I'm happy to introduce our speaker for tonight, Tom Dayspring, well-known figure to many of us. Tom is a fellow of both the ACP and the NLA and is certified in internal medicine and clinical lipidology. He practiced in New Jersey for many years. When I met him, he was director of the New Jersey Institute of Menopausal Lipidology. But in 2012, he moved to Virginia and became an educational director for several cardiovascular foundations and chief academic officer for two major cardiovascular laboratories. Since 2019, he's been a virtual lipid specialist for the prestigious national practice, Dr. Peter Attia's early medicine practice. Tom's done over 4,000 lectures in all 50 states, several other countries, and numerous podcasts. He's been an associate editor for the Journal of Clinical Lipidology and has published several book chapters and manuscripts, which I'm happy to say I was co-author for a few of these. Tom was, I think, the first recipient of the NLA's President's Award for services in clinical lipidology, and now he has just been selected as the 2023 Foundation of the NLA Clinician Educator. Tom is very active on Twitter as Dr. Lipid, and he serves as a social media ambassador for the European Atherosclerosis Society and for the NLA. And I think certainly it's probably true that half of us in the NLA are here because of Tom. I know I am when I met him in January of 2000. So tonight he's going to talk to us about ApoE for the clinical lipidologists. So Tom, take over.
All right, let's.
And while you're doing that, Tom, one last thing. I want to mention our next lecture is coming up in about a month, which will be Kelly Notice talking to us about prevention of Alzheimer's disease. So that's going to be very exciting also. Go ahead, Tom.
All right, except her name is Neotis.
Oh, it's Neotis? I didn't know. I've never heard it out loud. Thank you.
And she is in the practice I work with also, and she's astonishing what she knows about the brain. And really, we as lipidologists try and get in early and prevent atherosclerosis. And she's one of the very few and first, what she calls preventive neurologists, who very early in life will figure out, are you destined for chronic brain disease? And they believe there are several steps that if you take early enough in life, you can diminish that. And ApoE is the topic tonight. And you see, there's really two whole parts to ApoE. The first part of our lecture is, and probably 60 to 65% of it is discussing ApoE in the periphery. The periphery is everything but the brain. But then we get into the brain, and it's a whole different lipid and lipoprotein situation, and it has nothing to do with what goes on with lipids in the periphery. So you almost have to learn two lipoprotein areas, what's going on in each. So anyway, speaking of that Peter Attia guy who runs the early medical practice, if you haven't bought this book, you should. It's #1 on the New York Times nonfiction bestseller list. And it's full of amazing things for those of us who want to get in early, practice medicine 3.0, and prevent problems before they are problems. So Peter, in his book, certainly deals with the ApoE, and he tells us it's the gene involved with cholesterol transport and processing, and has 3 variants, 2, 3, and 4. There are actually more than that, but those are the common ones. And he notes in a meta-analysis of 7 longevity studies of 30,000 patients with at least 1 copy of an E2 compared to E3, the wild type, they were 30% more likely to have longevity, both males and females. But if you unfortunately have an E4 allele, the odds are far not on your side that you're going to see longevity. Other genes correlated with extreme longevity, interesting, are loss of function of CETP and ApoC3. So listen, I think we're close to maybe getting a CETP inhibitor on the market, and maybe you ought to just go on it for longevity, but better to inherit loss of function of CETP. But this is very important. Having 1 or 2 copies of the E4 variant increases the risk of Alzheimer's disease by a factor of 2 to 12. Now, there's my famous lipid lipoprotein slide. You know, in a centrifuge, you can separate particles by their buoyancy, and we also know the diameter of them. But I just brought this up to show you two terms. What is an apoprotein? It's any protein that can affix to any other molecule. However, if an apoprotein affixes to lipids, then you have something called an apolipoprotein. I'm a stickler for definitions, and most people use them interchangeably, but there are differences whether you say apoprotein or apolipoprotein. All right, this is another key thing to recognize. You all know buoyancy or density is a physical attribute of lipoproteins based on where it separates in a salt solution in an ultracentrifuge. And these are the densities of the various lipoproteins we're used to dealing with. Notice chylomicrons float. They don't even sink in there, but the other ones start to sink depending on their density. But I wanted to point out, you see LDLs there, and they're in that density range. And we all think of LDLs as an ApoB enwrapped particle that has that density. And if you were looking at an LDL in the peripheral plasma, that is true. But there are LDLs in the brain, and because they have the density like that, but they carry no ApoB whatsoever. So be careful what you think an LDL is. If somebody tells you there's LDLs in the brain, that's probably true, but it doesn't have ApoB on it. So it has to have a different apoprotein on it in the brain, and we'll get to that. All right, way back in 1973, I was a first-year resident, and I certainly wasn't reading the Journal of Lipid Research at that time. Had I would have seen that researchers discovered that, wait a minute, most VLDL species seem to contain more than one type of protein. And some of the VLDL species are deficient in one or more of the proteins found in other VLDLs. So they concluded that these proteomic differences among VLDL species probably has something to do with what happens to VLDL particles. And of course, the apoprotein they're talking about turned out to ultimately be ApoE3. All right, so there's a triglyceride-rich lipoprotein. It could be a VLDL or a chylomicron. And I'm not going to show you all the apoproteins that might be on them because there could be other ones. But the main apoproteins you're going to find on these is one molecule of ApoB48 from the gut or ApoB100 from the liver. You will find several copies of ApoC2. And as a reminder, that's the major ligand for lipoprotein lipase, which is how the triglycerides undergo hydrolysis when ApoC2 connects with lipoprotein lipase. But ApoE is found in multiple copies on chylomicrons and VLDLs. So ApoE must perform a certain function for whatever happens to those particles. So ApoC2 and E are essential for the physiological metabolism of chylos and VLDLs. Without C2, there would be no lipolysis. Without ApoE, the liver wouldn't be able to clear these particles as readily as it does. ApoE is synthesized primarily in the liver, but also in the brain, specifically mostly in the astrocytes, which is one of the glial cells in the brain. And very interesting, you see I underlined it, macrophages in the arterial wall can produce and secrete ApoE. And that's going to be very interesting, and we'll get to that. The gene for ApoE, if you're interested, is on chromosome 19, and it's kind of linked to C1 and C2 genes, and not too far from the LDL receptor. Of course, ApoE is going to turn out to be a pretty big ligand for that. It's an arginine-rich glycoprotein, and I note the molecular weight, 34 kilodaltons. In comparison, the molecular weight of ApoB is 550 kilodaltons. So ApoE is super important, but it's nowhere near the size of ApoB. ApoA1, which is another important structural apoprotein, I think it has like 25 kilodaltons, even smaller than ApoE. It's found on all plasma lipoproteins and is a major constituent on the VLDLs, IDLs, and HDLs, but rather sparse on LDLs, and that's crucial. It is absolutely the major carrier of cholesterol in the brain. So remember, I was teasing you that might be LDLs in the brain and HDLs for sure. But the main protein on those brain lipoproteins is apoprotein E. There is zero ApoB in the central nervous system. There'll be a little bit of ApoA1, as we'll get to. ApoE particles help transport lipids from the sites where they're synthesized or absorbed to cells where they are needed, because it's part of those lipoproteins that are carrying those synthesized or absorbed lipids. It can also help because it's a ligand for a hepatic LDL receptor, which clears particles and lipids, so it's involved with reverse cholesterol transport. And it may have a paracrine-like role where it can grab some lipids from one cell and give it to another one. Unlike the big difference between ApoE and ApoB is ApoE is transferable, meaning it can jump back and forth between various lipoproteins, whereas ApoB is fixed. Whatever lipoprotein ApoB 48 or 100 is on, it's with that particle from the day it's born to the day it gets internalized and catabolized. Large triglyceride-rich particles, kilos and VLDLs, as soon as they are secreted, acquire ApoE from HDLs. Now, I told you the intestine can't make ApoE, so enterocytes are not putting ApoE on chylomicrons, but they rapidly secrete chylomicrons into lymphatic circulation, and lymph is full of HDL particles, which are loaded with ApoE. So the HDL could say to the chylo, here, take some ApoE because you're going to need it. And the same with VLDLs. VLDLs might come out with some ApoE on it from the liver, but they gather more copies from circulating HDLs. One of the big functions of HDLs is it's sort of, I heard Dan Rader call it a flatbed truck that carries a lot of proteins that it can share with other lipoproteins. During lipolysis of triglyceride-rich lipoproteins, those particles get smaller, smaller, smaller. So some of the ApoE will be lost during the shrinkage of lipolysis. And what happens to it? It jumps on the nearest HDL particle and stays with it until it's needed by another chylo or VLDL that comes out of those organs. Very interesting. So ApoE is bouncing around a lot. But also ApoE remains, several copies remain on those big chylos and VLDLs. They've lost their triglycerides. They still have their cholesterol. So you know those are the chylo or VLDL remnants. They are much smaller than their parents. So as they shrink, ApoE shrinks and changes conformation, and it forms a shape that is a perfect ligand for the receptors on the liver that are going to clear chylomicron remnants and VLDL particles. So it's so cool. Initially, it wouldn't attach to the receptors, but as the particles shrink and ApoE transforms into a different conformation, it becomes a great ligand for the receptors we're going to talk about in a moment. Now, interesting, IDLs, because they're much smaller than their VLDL parents, have fewer copies of ApoE than VLDLs. And almost, you'll see what the percentage is, very few LDLs contain ApoE. And evolution made it that way for a certain reason. Because of its affinity to receptor binding, ApoE on ApoB particles is the major determinant of ApoB particle plasma residence time. What are the particles with the shortest residence time? Chylomicrons, multiple copies of ApoE. VLDL particles, multiple copies of VLDL. IDLs, less copies, but still way more than LDLs. LDLs, very few, if any, copies on 90% of them. And that's why LDLs have prolonged plasma residence time of several days. And the reason LDL was granted that privilege to float around, it's not delivering cholesterol and most of the time, it's accepting cholesterol transferred from HDL particles via CETP, and the LDLs then return that cholesterol to the liver in the indirect reverse cholesterol transport pathway. And them not having ApoE allows them to hang around, and for HDLs, which do help delipidate cells of cholesterol, to transfer it to the LDLs. The lack of ApoE on LDLs explains what I just told you. All right, there are two pools of unrelated ApoE containing lipoproteins, those that we'll find in plasma and those that we will find in the brain if we could get into the brain and analyze it. And the lipoproteins in the brain have nothing to do with the lipoproteins in the plasma. They are called the same thing because they're called based on their density, but the proteome is going to be considerably different. And there are no gigantic particles in the brains of the size of a VLDL or chylomicron. Most of them are of the HDL size in the brain. Some make it as big as a small LDL. In the peripheral circulation, ApoB and APO1 HDLs are the structural apoproteins, with ApoE joining those particles, but serving some of the secondary functions that I just told you about. It's really helped get those particles cleared. ApoB containing plasma lipoproteins under no circumstances can cross the blood-brain barrier. And where is most of the cholesterol in our plasma? In the ApoB particles. And tells you they cannot possibly supply the brain with cholesterol. So nobody ought to get nervous if they're making LDL cholesterol 10 with some of our great new lipid modulating drugs, that you're possibly hurting the brain. No, the brain, you'll see, makes all the cholesterol it needs. Brain synthesizes also ApoE, but not ApoB. And the astrocytes are the major producer of ApoE, but no astrocyte can produce ApoB. So you're going to see in a little while that the lipoproteins in the brain are ApoE containing lipoproteins, whereas in the plasma, they're mostly ApoB or ApoA1 containing lipoproteins. But that little ApoA1, look at it on the bottom, that's got a lower molecular weight than ApoE, that can cross the blood-brain barrier. So you're going to have some ApoA1 on some of the brain lipoproteins too. Very interesting. Some ApoA1 can get in, and that means the HDL densities, the high-density lipoproteins in the brain, mostly will be ApoE containing HDLs, but several of them will combine both ApoA1 and ApoE, just like in the plasma. If you don't know it, I think I just told you, HDLs carry considerable ApoEs. So here's my little diagram showing you the ApoB containing lipoproteins and the ApoA1 lipoproteins. And I did stick ApoE under them because all of those particles can have ApoE, but it's extremely sparse on LDLs. It's actually a little more prevalent on Lp(a) than it is LDLs. You'll find a lot of it on HDLs, a lot of it on VLDLs. In fact, read the mass of ApoE on the various particles. 1% of LDLs, much more on the others. In fasting plasma, ApoE is found on most HDLs. It's almost 60 to 80% of them, 90% of them. Many VLDLs, 35 to 60%. A few on Lp(a) and almost none on LDL particles. By the way, if you did have an LDL that contained ApoE, its plasma residence time is much shorter than an LDL that doesn't contain ApoE. Why? Because an LDL has ApoB100 and ApoE, both ligands for LDL receptors. So if their ApoE-containing LDLs are cleared much more rapidly. We do know right now that there are basically 21, 19, and 5 molecules or copies of ApoE, respectively, on VLDLs, HDLs, and LDLs. And of the LDLs, it would only be a small percentage of them that contain the ApoE. Now, this is one of those Dayspring slides you could spend all night on, and I'm not. You see 5 ways I've elucidated what ApoE can do. The linear of ApoA1 is the circle 1 with the yellow. ApoA1 is secreted by the liver. It can also break off of intestinal chylomicrons. ApoA1 rapidly lipidates into pre-beta. With LCAT, it esterifies, and you start forming more and more mature HDLs that ultimately are cleared by scavenger receptors B1, which can be expressed in several tissues. Notice circle 2. Hey, the liver secretes ApoE. It can do exactly what ApoA1 is. It's a helical protein of the similar molecular weight. It can attach to ABCA1 transporters and accept cholesterol. LCAT can help esterify the cholesterol, and you can have large ApoE-containing HDL particles. ApoE turns out to be a ligand for the scavenger receptor B1 like ApoA1, and it can be delipidated. Number 3, you see an LDL being secreted by the liver, or if you look from the bottom up, of course, you know some VLDLs after lipolysis generate LDL particles. I do show some ApoE there, but it would be very sparse on the LDLs. And ultimately, the LDL is going to be cleared at the liver by the LDL receptor. The VLDLs come out, several copies of ApoE. They undergo lipolysis, change into chylomicron remnants, or excuse me, VLDL remnants. And because VLDL remnants have both ApoB100 and a couple of copies of ApoE, they are rapidly cleared by one of two receptors in the liver, LDLR or LRP. And of course, the chylomicrons have even more copies, and that's why their plasma residence time is so short. They undergo rapid lipolysis, lose their trigs, lose their surface phospholipids, which are used for HDLs to mature, and you have a chylo remnant, which is rapidly cleared, mostly by binding to the LDL receptor-related protein. But there is some ApoE on there, so an LDL receptor could clear a few chylomicrons. Dan Rader is the first I ever knew to coin the term macrophage reverse cholesterol transport. And that's the process where HDLs can go into the artery wall and somehow delipidate foam cells. Macrophages filled with sterols. And obviously that would be good. That would help shrink plaque over time if you could induce this. And this is the standard way of how we were taught it was done. Large HDLs can accept cholesterol through the ABCG1 efflux transporters. Small HDLs, unlipidated ApoA1, can accept free cholesterol from ABCA1 transporters. HDLs can accept cholesterol ester via the two-way receptor, scavenger receptor B1. SRB1 can delipidate particles or it can lipidate particles. Cholesterol ester can go both ways there. And of course, free diffusion can occur at any cell, including a foam cell. We all know that. This is a classic teaching. But now, who knew that macrophages synthesize and secrete ApoA1, which basically acts like a unlipidated ApoA1. It can attach to ABCA1 and generate very small pre-beta HDLs, except they're ApoE-containing HDLs. And LCAT will be on there, and it can esterify the cholesterol, and ultimately you'll mature to a larger EHDL, and EHDL can accept cholesterol ester from a scavenger receptor. So ApoE is nice to have. Thank you, Mr. Macrophage, for secreting that. The plasma concentrations of lipid-rich lipoproteins and their metabolic fates are modulated by apolipoproteins. We all know that. One day we ought to have a lecture on every single apoprotein that we know and try and go through what their functions are. And certainly the genetic variation in these apolipoproteins is a major determinant of inter-individual variation. You're going to see that in a little while because you know ApoE comes in different variants, and so do other apoproteins, to be honest, and they will perform a little bit differently. Liver-derived ApoE is the main source of plasma ApoE, which I've already told you is a multifunctional protein involved with several processes, and most of them have to do with the ability of lipoproteins to transport and carry lipids and to be internalized by various receptors. It binds to the receptors on the liver to mediate clearance of certainly the ApoB particles. ApoE also facilitate HDL particle SRB1 delipidation. So an HDL can bind to a scavenger receptor via ApoA1 or via ApoE, which HDLs carry. It's a ligand for the LDL receptor, the LDL receptor-related protein, VLDL receptor, which is like LRP, the ApoE receptor 2, which most of us have never heard about, and the scavenger receptor B1, as I've so far elucidated. ApoE also can react with lipoprotein lipase, and that's another way it can affect lipolysis, or you'll see in a certain circumstance why IDLs don't get cleared and what's happening depending on their ApoE content. So I just wanted to show you a little bit about the ApoE receptor 2, sort of like the LDL receptor-related protein, not 1, but 8, and it belongs to the LDLR family. And if you look at that graphic, if you've ever seen a graphic of the LDL receptor, it sort of looks the same, but this is a big player in the brain. In the brain, ApoER2 is mainly found in neurons and is involved with the regulation and activity of N-methyl D-aspartate receptor, which is critical for synaptic function, learning, memory, and also plays a role in the clearance of amyloid. And you know ApoE is going to turn out to be a big player there, and especially what variant of ApoE you might have. So that receptor's That's why we were never taught about it. It's in the brain, because I don't remember ever being taught anything about the brain and lipids in my many years in the field. So this is sort of a summary of all the things ApoE can do. And we've talked mostly about the upper left-hand thing there, the clearance and effluxing of particles. But listen, these triglyceride-rich particles can be delipidated at adipose tissue. ApoE helps bind to the receptors there. The brain, it's everything, and you can see there are other functions. ApoE can, HDL particles are the major supplier of cholesterol to steroidogenic tissue, and they bind to adrenal or gonadal SRB1 via ApoA1 or ApoE, and they can be delipidated and deliver cholesterol to those organs. Very quick, we'll go through this. There's the liver, and you see step one, VLDL particles are being made and ApoE is being made. They are secreted, and HDLs can start sharing other apoproteins to the VLDL of the C family and the ApoE family. The VLDL undergoes lipolysis, where lipoprotein lipase is expressed, and then it turns into a VLDL remnant. The VLDL remnant can acquire as it shrinks, it gives its ApoE back to HDL particles, which becomes a carrier until it has to share that ApoE with other particles. And of course, VLDL is cleared at the liver, VLDL remnants are cleared at the liver, and LDLs are cleared at the liver. So, and ApoE helps all of those steps that you see there. But there are common and rare variants of ApoE that can cause what we're in business for, dyslipidemia, especially where triglyceride-rich lipoproteins are involved. And if you have different variants of ApoE, if you look at top, you'll see there will be difference in production, the stability, the lipid binding affinity, how it interacts with lipoprotein lipase, and all has tremendous influence on how well the various receptors in the liver can clear these triglyceride-rich particles. And we'll go into that in certainly more detail. So it's a polymorphic protein with 3 common isoforms, and there are many rarer variants, as I hinted. I have to tell Peter to correct his book that there are more ApoE variants. But the 3 most common we're all familiar with are ApoE2, E3, and E4. Genetically, these correspond to the various alleles, 2, 3, and 4. But since we get one allele from mom and one allele from dad, we're going to have mixtures. You could have pure E2, pure E3, pure E4, or E2, E4, E2, E3. There's a lot of variations you can have. E3 and E2 preferentially bind to HDLs, and E4 likes VLDLs, and you're going to see the consequences of that. The binding affinity of ApoE2 for the LDL receptor is less than 2% that of the affinity of ApoE3 or ApoE4. So interestingly, ApoE4, which is going to turn out to be the bad guy where lipids are concerned, is rapidly cleared by the liver. Where ApoE2, where you're pretty much protected against vascular disease and dementia, except for a rare situation, doesn't get cleared, but there's far less cardiovascular risk in ApoE2 patients. So if you don't know that, there's only one amino acid difference between these 3 variants, 2, 3, and 4. You see 4, there's a substitution of arginine for cysteine. In ApoE2, there's a substitution of cysteine for arginine. That happens, it just changes the way ApoE can bend, and shape is everything with a protein on what it's going to bind to and influence. On the bottom are all the minor isoforms you might find around. I don't think I've ever seen an E7, but I don't think I've ever had anybody test for an E7. Here are the prevalence of the various ApoE genotypes. So you can see the by far the most common, it's the wild type, is ApoE3E3. That's most of us. But ApoE2E2, which is protective against brain disease and atherosclerosis, only 0.4% of the population will have it. And you can see the prevalences of the other one. ApoE4, E3, E4, 14%, E2, E4, less than 1%, E4, E4, thank God, only 2%. By the way, next lecture, when Kellyanne Neotis talks to you, if she gets anybody with an E4, she will have very strong suggestions of what you should do with it. And this is why you want to get an ApoE genotype early in life in people, just like we want to get Lp(a) early in life in people. We can do things to these people who carry these genes we wish. ApoE2E2, you've been taught, is mostly associated with familial dysbeta lipoproteinemia. Fredrickson called it type 3. And E4E4 is associated with increased ASCVD risk. And if you don't know it or not, when you see an E4, you better do sterol absorption tests, because there's a high incidence of hyperabsorption of cholesterol, which probably explains some of the risk associated with E4s. They also have a tough time absorbing omega-3s. So you will find E4 carriers deficient in omega-3s, and they all should have the omega-3 index done on them, and they can be supplemented, and that can be easily corrected. I'm not going to dwell on this, but you see the differences are just one darn amino acid in specific regions of the ApoE peptide, and the consequences occur. But I just want to remind you, when you order ApoE, people get confused. We order ApoB, what do you get back? A concentration. Very few of us are doing ApoB genotyping without very specific indications. But with ApoE, we're not measuring the concentration. We're measuring what the genotypes I just described, which are important, and you can base some conclusions off of them, but understand genotype versus concentration. A little question, should we be measuring the concentrations of ApoE? I think we're going to get to that right here. So this is an interesting study where they looked at mostly men who were had chronic coronary syndrome, who were going to undergo percutaneous interventions. They all were on statins, and they wanted to see, if you measured the ApoE concentration, did it provide any insight about anything? Mostly males. Here's what the concentration of ApoE is in the blood. The median is 3.5 milligrams per deciliter, and you can see it goes from 3.0 to 4.2. What's the concentration of ApoB? 80, 90, 100, higher? How about ApoA1? 30, 40? So you can see very small. The mean was 3.7. So they declared that if you had an ApoE concentration greater than 3.5, you had elevated ApoE concentration. If you were below that, you were lower. Did it matter? It did. And you'll see a graph in a second. The major findings of this study shows high pre-procedural ApoE concentrations was significantly associated with a higher incidence of MACE compared to lower ApoE in coronary artery disease patients who all had statin-induced LDL cholesterol below 100. Now, remember, statins mostly remove LDL particles from the blood. So statins are not reducing ApoE much in the brain, or excuse me, in the blood, because LDLs don't carry ApoE. So very interesting. Hey, we're told, hey, do CRP or do an omega-3 EPA level to determine residual risk. Maybe we ought to just check ApoE concentrations. I don't know any labs that do them. It's a very easy immunoassay, just like ApoB is, and it might provide some insight if we were doing. The group with the higher ApoE concentrations had higher lipid levels, as you can see, higher ApoB, which I don't like, higher remnant cholesterol levels, and increased triglyceride to HDL-C ratio. And many people no longer use the LDL-C to ApoB ratio. In the old days, that's how we guessed what LDL size was. LDL-C, if it's low compared to ApoB, you had small particles, whereas just the opposite if the ratio was high. So on the x-axis, you see the various ApoE alleles. ApoE3, the wild type, is right in the middle and colored red. And the odds ratio for ASCVD is on the left. And you can say, boy, I'd rather have E2 alleles because there is less atherosclerotic risk. I don't want to have E4 alleles because the atherosclerotic risk goes up. This is what happens to lipids based on ApoE genotype. And basically, the top one is LDL cholesterol. You can see it goes up with the E4 alleles. It goes down with the E2 alleles. There's really no effect on HDL cholesterol, and triglycerides kind of null. So those are the differences. Very interesting. If you have ApoE2, it lowers total cholesterol by about 14 milligrams per deciliter, whereas ApoE4 raises it. It's even more significant if you compare to LDL cholesterol. So if you're born with E2, you're born like you're on a statin already the day you're born, because you're going to have lower ApoB and LDL cholesterols through life. And we know time means everything with lipoproteins being deposited in your artery wall. So very interesting data. So here's ApoE3. There's the liver. LRP is the LDL receptor-related protein. LDLR is an LDR. Now, up above, now this isn't a normal person, ApoE3, who doesn't have a lipid disturbance. You see the triglyceride-rich, well, they're more cholesterol-rich, triglyceride-poor, remnant particles of chylose or VLDLs. Because of the ApoB48 on chylose or the ApoE on VLDLs, they rapidly bind to LRP. They get internalized, and that's how gut cholesterol gets brought to the liver, to the chylo. The VLDL is just returning cholesterol that was put in it when it was constructed, but even VLDLs accept cholesterol from HDLs via CETP. So VLDLs are in part participating with direct reverse cholesterol transport. Now, down the bottom, you see different size LDLs. And of course, they have ApoB100, and they are cleared efficiently by the LDL receptor. Lipidologists, we know how to express more LDL receptors to keep them expressed, which is how we lower or induce clearance of ApoB particles. Now, here's an ApoE4 containing triglyceride-rich, well, it's cholesterol-rich remnant. And because of the ApoE4 has tremendous affinity for LRP, these particles disappear virtually instantly after lipolysis at muscles or fat cells occurs. And wow, so you'd say that's good because you're getting remnants out of the circulation, but it's bad because they deliver so much cholesterol to the liver doesn't want any more cholesterol. It's toxic. It can create fatty liver. So what does the nuclear transcription factors in the liver do? They downregulate the expression of LDLRs. So the LDLs cannot be cleared. So you have decreased LDL clearance. And that explains the high risk of people with ApoE4. They got way too many ApoB LDL particles, even some VLDL particles that just cannot be cleared. That would be VLDLs that don't carry ApoE. Now, how about ApoE2? ApoE2 has terrible binding to the LDL receptor-related protein. So, but in a normal person who doesn't have super high trigs, there are very few of these remnants. The ApoB concentration devoted to those remnants in somebody with normal lipemia is very small. So they come, they dump their cholesterol there, not very well, because most of them don't get in. So that means the liver is depleted of cholesterol. And what does the liver do? The nuclear transcription factors express more LDL receptors, and they rapidly clear their LDL particles, which contain no ApoE, only ApoB100. So the LDL particle concentration is decreased. The ApoB remnant concentration is increasing, weensy, but if you're looking at ApoB, it drastically disappears because remnants contribute little to the ApoB concentration. And in this normal lipemic situations, there's just not that many remnants that are going to do anything. Ultimately, they do get cleared, just takes a longer time. Now, any lipidologists who've been around long enough, especially old guys like me who go back to the old days, used to see these type of xanthomata. And there are tendon xanthomas on the hand, on the elbow. We have xanthelasma on the eyes. And few of us have ever seen palmar xanthoma. I saw it once when I attended Pete Quittervich's John Hopkins lipid course, where he actually brought in a patient who had palmar xanthoma for us all to look at. And of course, you can get Illy xanthoma. So what is the diagnosis, or what might you be thinking of with this patient? And especially if you saw, wait a minute, the ApoB is low, the calculated LDL cholesterol is high, but if you do an NMR, you won't find many LDL particles. And if you do a directly measured LDL cholesterol, it's opposite of what the calculated LDL cholesterol is. So it's a sort of a trivia question. What gives you high calculated LDL-C, low direct LDL-C? What gives you normal ApoB with monstrous lipid abnormalities? I think you probably all know it's the type 3 familial dysphagia lipoproteinemia. So if the IDL and VLDL remnants are enriched with ApoE2, can't be cleared. The IDLs can't be cleared. Because the IDLs are, as the VLDL shrink, they're not getting, they can't bind to the LDL receptor, which is mostly where hepatic lipase is expressed, and IDLs get converted to LDLs. Very few of the IDLs get converted to the LDLs. Yet the LDLs, because they have ApoB100 and no ApoE, they're rapidly cleared. So what explains the horrific lipids in these patients? It's a remnant disease. It's chylo and VLDL remnants and IDL remnants. And remember, those remnants can cause very bad lipid disturbances, but because there's so few of them, they're engorged with lipids, explaining the lipid concentrations, but the ApoB level is unremarkable. And why is the calculated LDL cholesterol out of whack? Because calculated LDL cholesterol includes the cholesterol in IDL particles, whereas directly measured LDL cholesterol does not. So that explains the paradox of how calculated LDL-C differs from measured LDL-C. The association of the familial dysphagia lipoproteinemia has been pretty well documented with the ApoE2 phenotype, but beware, it can occur in people who don't have ApoE2. Who knows why, but it's far more common with ApoE2. And it's all due to the defective binding of ApoE2 to many of those receptors. So we have increased triglycerides, total cholesterol levels. Why? Because the VLDLs and chylos and IDLs carry a lot of cholesterol. Presence of the beta VLDL cholesterol-rich remnants, chylomicrons, but unremarkable ApoB, and you see what your skin looks like if you're not under treatment of that disorder. I explained to you why the calculated LDL-C differs from the directly measured, and it's all IDLs which contribute to calculated LDL-C, but not to directly measured. And interestingly, although ApoE2 is going to predispose you to this, 90% of homozygous E2 patients have perfect lipid levels and low cardiovascular risk. So why in 10% of people does this phenotype show up? There has to be what is called the second hit, which raises triglyceride, which of course creates those big particles that cannot be cleared. You want, what is the second hit? Look at all those things on the right. If you have E2, and any of those other things are there, you might convert to a type 3 hyperlipidemia. Just many things, and you have to figure it out. And obviously, if you did figure it out, you could tell that patient, let's stop that. Alan Schneiderman is the master of how to diagnose this. You've all seen his algorithm on how to do this, and he's published several papers on this. He will tell you fewer than 1 in 20 of the E2 phenotypes will get type 3. Those with abnormal ApoE or absent ApoE, not going to be identified with those rarer variants. If you're doing ultracentrifugation, there's an easy way to tell. Most of us are not. So looking at a lot of patients, they decided this is how you diagnose type 3. You divide total cholesterol by ApoB. If it's greater than 6, you then divide triglycerides by ApoB. And if that's less than 10, bingo, you have a type 3. You can, using that ratio, identify type 2, 4, and 5 also. but it's type 3 that is the most dangerous that you want to know about. And this is why you got to do ApoB on every lipid profile, because you will miss it doing the lipid profile. You just think, oh, I got a high trig thing. I got another insulin resistant person. You have type 3. The risk is way worse if you have a type 3 person. So you want to know it. And this just talks about some of these rarer variants of ApoE, and they've now found out that it can contribute to one of the causes rare of autosomal dominant hypercholesterolemia. And it is a fairly new article just published. So they believe that we have to, normally if we see somebody with a nightmare LDL cholesterol, we send for, hey, the usual defects, PCSK9, LDL receptor defects, a defective ApoB. They believe we should add ApoE variants to your screening for familial hypercholesterolemia. Because you don't do it, you'll mess them. You'll say, you don't have a defect that we can identify. And it's always nice to identify the variants because they help you with your risk equation. Now, more on HDL particles, because it's very interesting how ApoE can modify them. So an HDL is a protein carrier family of lipoproteins, and it can carry most of the apoproteins, including ApoE. And you see that. All right. But there's the total cholesterol level, is the cholesterol in all your HDL particles. What if we measured, hey, I'm only going to separate the HDLs that have ApoE on them, and then you would get HDL ApoE cholesterol concentration. Would that be interesting to know? Would that have any use in the lipid clinic? Well, this is a fabulous little article here. One of the first that showed, hey, everybody who's walking around with a very high HDL cholesterol, you're not immune to heart disease. Some of you might not get it, but some of you will. So how in the world would we know that? So using carotid intimal thickening, they examined various types of HDL particles, and they noted there are substantial variations in cholesterol content per HDL particle. And some individuals have cholesterol overloaded HDLs. Well, if you do, you're going to have a high HDL cholesterol level. So they say cholesterol-rich HDLs can be a strong predictor of carotid atherosclerotic risk, which implies that in cases of high levels of HDL cholesterol, you should not be patting everybody on the rear end and saying you're protected, because some of them are not. Can we figure this out? Who with a high HDL-C might be in trouble and who might not be? Well, they found some interesting findings. So they looked at both the cholesterol content of the HDL particles and the particle number. And ultimately, they looked at the cholesterol content of just ApoE-containing HDL particles. The first thing, they said, hey, this can probably help us figure out who's at risk for ASCVD. I could do a whole lecture on this, but here's the conclusion. Now, on the y-axis is your risk for carotid atherosclerosis. On the x-axis, when you go from right to left, you go from low HDL cholesterol to high HDL cholesterol. On the other y-axis on the right side, or whatever that's, I don't know if that's a continuation of the x-axis, you go from high HDL towards the front and low HDL particle count towards the back. Who were the highest people with the highest atherosclerotic risk? They had high HDL cholesterol, but they had very low HDL particle counts. So what that tells you, if you have a very high HDL cholesterol and you have not many HDL particles, the few HDL particles you have must be jam-packed with cholesterol. By the way, a normal HDL particle carries about 45 molecules of cholesterol. These cholesterol-engorged one carries 50, 60 molecules of cholesterol per particle. And that's an easy way. Just divide HDL-P by HDL-C in molar concentration using NMR. Now they went and looked at the people with the ApoE HDL particles, and they evaluated them by separating those particles and measuring the cholesterol in the ApoE containing HDLs versus the cholesterol in the HDLs that didn't contain ApoE. So basically, here's the conclusion. You see two cholesterol overloaded HDL particles on the top, but the one on the left has very few ApoE peptides attached. The one on the right is ApoE enriched. High cardiovascular risk on the right, low cardiovascular risk on the left. So the one way you could tell a person with high HDL cholesterol you're doomed or not doomed is if we could get a metric of ApoE on HDL or HDL ApoE cholesterol. I'm sure you'd have to have a research lab to do that. But ApoE is part of the story here. But I'm not done with the HDLs, because there's a third type of HDL you see on the bottom, which is carrying ApoC3. Now, ApoC3 is 9 kilodaltons. It's a tiny, tiny apoprotein. But as lipidologists know, it's a tiny apoprotein that can create great havoc sometimes. And if you don't have ApoC3, you're going to have longevity, as Peter Attia told us. So they looked at this population now in the Danish Diet, Cancer, and Health Study. And from left to right, quartiles 1 to 5, you had increased concentrations. So if you look just at HDL particle concentration and the ApoE on HDL, didn't matter. But now if you looked at the ApoE concentration in people who had high ApoE HDL cholesterol, you can see as that went up and up, there was cardioprotection, where God forbid you had HDLs, whether they contain ApoE or not, that didn't contain or that had ApoC3, you're in big trouble. So the conclusion of this, when human HDL is separated into subspecies containing or not containing ApoC3, the concentration of HDL that contains ApoC3 predicts higher risk of CHD, where HDL that does not contain ApoC3 predicts lower risk. These opposing roles of ApoE and ApoC1 in humans have long been known on the ApoE particles. Frank Sachs has been studying these for years. You know, an ApoB particle that has only ApoE and no C3 has rapid clearance. If you have E3 but also C3, you have delayed clearance, and you have no ApoE and only C3, you're in big trouble. So I wish we could somehow assay these apoproteins in our patients, and especially where trying to solve these dilemmas with high HDL cholesterol, we would have a better answer if we could measure HDL ApoE cholesterol or HDL ApoE or ApoC3 content. All right, that's the periphery. There's a lot more to it, but that's enough for tonight. Let's get up into the head. This is interesting if you don't know it. The brain has the highest level of cholesterol in the body. So total body cholesterol is in the brain, and it has zero interaction with the cholesterol in the periphery. The blood-brain barrier effectively prevents the uptake of lipoprotein-bound cholesterol from plasma, and accordingly, cholesterol level in the brain is extremely, totally independent from that in plasma and peripheral tissues. So never panic. Oh my God, whatever drug I'm using made the HDL-C 20, or you have a patient with hypo-beta lipoproteinemia who, because of genetics, has an LDL cholesterol of 20. Their brains are not suffering. Their brains have all the cholesterol it needs. These concentrations of cholesterol are crucial in the brain, because what is the major function of cholesterol even in the periphery? It gets into cell membrane, affects lipid rafts and cell membrane functioning and signaling, which is everything, especially in neurons on the brain. So you need cholesterol in the brain. Just like in the periphery, too much cholesterol in the liver causes fatty liver. Too much cholesterol in the brain causes Alzheimer's disease, or it's associated with Alzheimer's disease. So we have to have good cholesterol homeostasis in the periphery and the brain. And we'll show you how the brain does that. The pool of cholesterol is 2.2 milligrams per gram of body weight in the whole. The cholesterol pools in the human body exist in the CNS, the plasma, and in peripheral tissues. In the peripheral pool, cholesterol is mostly supplied by de novo synthesis. Dietary intake, of course, is part of the peripheral cholesterol, but 70% of our peripheral cholesterol is synthesized. Only 30% comes from cholesterol you absorbed. And to be honest with you, a large part of the cholesterol we absorbed is recirculating endogenously produced cholesterol that made it to the gut via the biliary tract. So really, ingested cholesterol is a small supply of total body cholesterol. Most organs meet their tissue cholesterol requirements through endogenous biosynthesis. Those organs that need extra cholesterol, steroidogenic tissues, get it after synthesis from HDL particles. They do not depend on LDL particles to deliver cholesterol to them, which is why hypo-beta-lipoproteinemia or drug-induced hypocholesterolemia does not affect steroidogenic tissues. The liver accounts for only about 15% of cholesterol synthesis. Most lipidologists, you go up and, oh, the liver makes all the cholesterol. Not even close. The vast majority in the periphery is made in the cells, all the organs and the tissues in our body. The liver is one of them. It makes a lot, but so do the other cells. The CNS synthesizes every molecule of cholesterol it has. And abnormal cholesterol metabolism, be too much or too little, is bad news in the brain, as you will see. Here, I can't hammer this enough. CNS cholesterol, although significant in mass, does not exchange with other body pools of cholesterol. That is an incredible reference that every lipidologist should read. There ought to be 10 questions on Hellerstein's article, and the next time they give the lipid boards. It's so important. This you're going to, if you don't know it, it's going to shock you. The half-life of a cholesterol molecule in the brain is 6 months to 5 years, where the half-life of plasma cholesterol is only a few days. And you know, if a half-life is X, the true, when does that molecule disappear? You multiply the half-life like by 7. So you can see brain cholesterol, once it's made, the brain is happy. It's got it. And you know where a lot of the brain cholesterol is made? In utero or in infancy. And after that, the brain doesn't have to make much cholesterol. Cholesterol in neurons can be synthesized a little bit by neurons, as you will see, but most of the neurons' cholesterol is going to be taken up from other cells, mostly the astrocytes. And that's important because how many ATP molecules does it take to synthesize cholesterol? It's over 25. The neurons can't be making cholesterol because it needs that ATP for all its other functions, its synaptic functions, its ability to make our brains function. So the neuron saves ATP every time the astrocyte makes cholesterol and sends it over to the neuron. Cholesterol can be excreted from the neurons. You don't want too much cholesterol in the neurons. It'll crystallize and hurt those neurons. And guess what the neurons contain? The ABC family of cholesterol efflux transporters, just like the periphery. So if a neuron has too much cholesterol, it will efflux it through those transporters that you see there. And what will be the acceptor of the cholesterol? An ApoE containing lipoprotein. Wow. ApoE is expressed in the CNS, lipidates. As soon as it's produced by an astrocyte, it attaches to an ABC transporter and it receives its cholesterol. And then it can take that cholesterol from an astrocyte or other glial cell and deliver it to the neurons. So the astrocyte is like the liver cell as far as producing cholesterol. The liver is in the periphery. The astrocytes are in the brain. It has become increasingly clear that in addition to its role in the maintenance and physiology of the cardiovascular system, ApoE plays a crucial role in healthy and pathophysiological processes in the brain. In both the periphery and the brain, you better have normal cholesterol homeostasis. When ApoE is critical for the regulation of cholesterol homeostasis in the peripheral circulation, its role in the brain appears to involve not only cholesterol transport, but intracellular exchange of metabolites other than cholesterol between neurons and glial cells. And that's going to include, maybe Kellyanne will get into it, about the tau and the amyloid and all that other stuff that is not good for a healthy brain. So now here's the difference between your plasma and your CNS lipoproteins. Now, you're very familiar with the plasma lipoproteins, what they contain. CNS lipoproteins are very similar, except at best you'll get some small LDLs that are ApoE-containing LDLs. They have the density of an LDL in a centrifuge, but there's no ApoB on them. The ApoE is going to be or the HDL is going to be the predominant particle in the brain. And for the most part, they're ApoE or ApoE plus ApoA1 containing. And they are crucial to the brain health. They do most of the cholesterol exchange. This is a great picture. I want you to look at it closely. Astrocytes in green. You see the neurons in light tan. Microgliocytes are like the immune cells in the brain. Oligodendrocytes produce myelin, so they're kind of crucial. So oligodendrocytes require a lot of cholesterol. They can synthesize it, but astrocytes can send cholesterol to oligodendrocytes so they can function. Notice the astrocytes are the one that attach to the artery going through there, and that's where the blood-brain barrier is. Now, the crucial thing is, what's that tan background there? That's not blood. The blood is in the artery going through it, but nothing's coming out of that artery in the lipid lipoprotein world except some little HDL or ApoA1. That is the matrosome. And the matrosome is brain interstitial tissue, like brain connective tissue. So if an astrocyte is going to make an ApoE containing lipoprotein, it doesn't get to the neuron through your blood, your arteries in the brain. The astrocyte cannot secrete a lipoprotein into the blood. The lipoprotein created by astrocytes travels through the interstitial tissue, the matrosome, and it goes over to the neuron, which expresses the receptors that will delipidate it. So most people don't understand brain lipoproteins don't travel in the plasma. Peripheral lipoproteins, that's how they go back and forth. Matrosome is sort of like the plasma of the brain, except it's not connected with our arteries. 4 different types of glial cells. I've already explained them, except for those ones called ependymal cells. Notice they're on the top, and they separate the matrosome from what? The cerebral spinal fluid. And they can secrete a lot of garbage out of the brain. The cerebral spinal fluid is like the collecting system in our ureters and bladder. It gets the garbage and it can transfer it to the brain. Some things can go the other way from the CSF through ependymal cells and get in. But the CSF is the garbage system on how to get stuff out of the brain. There's that astrocyte. Kind of a scary looking cell, isn't it? But they are by far the most numerous cell type in the brain and the majority of the glial cells. And they're star-shaped glial cells. And if you want to read that, they have many, many functions, and especially controlling endothelial cells that form the blood-brain barrier. Wow. That's when the blood-brain barrier, an artery that has that, it's in the astrocyte where exchange of some things occurs. Astrocytes are the major source of cholesterol synthesis in the CNS, which reduces the neurons' requirement to use ATP. It can save ATP for other way more important processes. Apoprotein E, also produced in the astrocytes, is what accepts the cholesterol. Where does it get it? The astrocyte expresses ABCA1 transporters, which lipidate the secreted ApoE, and you form an HDL density or an LDL density ApoE-containing particle that carries its cholesterol to the neuron. We're not going to go into this much. The tan is the matrosome. You see the CSF up there in the or an artery with the blood-brain barrier. You see ApoA1 can get through, other molecules can get through, but no other lipoprotein or lipid can get through. But I want to, if you look at all the cells and you look at the bottom, you can see, wait, lipoprotein lipase, heparan sulfate proteoglycans, free fatty acids, not many triglycerides, HDL particles, LDL particles, remnants, which are really delipidated HDL particles, the lipoprotein receptors that are there, same as in the periphery, LRP, LDLR, scavenger receptor B1. Cluster in ApoG is an inflammatory apoprotein that can be made in the brain. Interesting. If I can read the legend to you, owing to the blood-brain barrier, the exchange of lipoprotein particles between the systemic circulation and CNS is minimal. I would call it non-existent, other than some very small HDL particles or ApoA1 can traverse the blood-brain barrier. Most of the lipoproteins inside originate from astrocytes, although some lipoprotein constituents can be synthesized and processed differently in neurons. Lipoprotein particles are synthesized, assembled, exchanged, and modified between astrocytes and neuron, and they travel through the matrosome. You know, in the blood, our lipoproteins may have to travel like miles to get where they're going. There's so many blood vessels. But these cells are so close to one another in the brain that an astrocyte-produced ApoE-containing particle has very small distance before it bumps into a neuron. And that's how you can have this type of circulation. Astrocytes can secrete lipoprotein particles into the CSF, basically some remnants of APO. You'll find some ApoC that can get secreted, and you can find certain molecules. And one we're going to talk about that you can find in the CSF is desmosterol, and you're going to get some interesting thoughts on that in a second. Lipoprotein receptors and lipoprotein lipase are on the surface of these cells, and that's how lipoproteins get metabolized in the brain, very similar to how they get metabolized in the periphery. ApoE is the only medium-sized apoprotein present in the brain and basically controls lipid homeostasis in the brain. The interactions with ApoE and ABCA1 is how we lipidate ApoE-containing HDLs. Once on ApoE or ApoA1, the cholesterol is esterified by LCAT, which is in the brain, and that's how the particles mature and get larger, and the the neuron using SRB1 can delipidate any cholesterol ester. Free cholesterol will be internalized by the LRP mostly, or the LDR in the brain. The mature ApoE containing HDL can interact, as I just told you, with SRB1, which will delipidate that particle and provide the neuron with cholesterol ester. ApoE containing HDL, just like HDLs in the periphery, no doubt have other functions. And I don't know when we're ever going to figure out HDL function in the periphery. And I would say in 100 years, we'll probably know about HDL functioning in the brain, aside from its lipid transportation. Existing evidence indicates that ApoE containing HDL through receptor-mediated processes, and remember I taught you about that ApoE receptor, can help sequester amyloid B away from the brain parenchyma and perhaps prevent amyloid deposition and plaque formation. You probably know New Amsterdam Pharma investigating obicetrapib, which creates large ApoA-enriched HDL particles and increases ApoA1 synthesis in the liver. They have the hypothesis that that drug will send ApoA1 into the brain, and if you have an E4 dysfunctional HDL particle in the brain, the ApoA1 can give the brain functional HDL particles, and they're hoping to see a reduction in dementia signal from the obicetrapib trials. Fingers crossed on that one. Astrocyte on the left, neuron on the right. You see the astrocyte makes ApoB, it expresses ABCA1, you lipidate, you have an ApoE lipoprotein, mostly of HDL buoyancy. It gets delipidated or internalized at the neuron, which can use the cholesterol in its lipid rafts to get perfect synaptic function. If there is too much cholesterol in a neuron, be it from production or delivery, it gets rid of it by effluxing it out of ABCA1. But you see, some cholesterol can be oxidized to an oxysterol called 24S-hydroxycholesterol, which can pass through the cell membrane, get into the matrosome, and interestingly, watch the bottom there, 24-hydroxycholesterol can be excreted through the blood-brain barrier into the blood. And that is the one way how the brain can protect itself from cholesterol overload. Create an oxysterol. That oxysterol can go back to the astrocyte and be reconverted to cholesterol, or it can be eliminated, and that saves the brain from cholesterol overload. Now, you got to take out your magnifying glass. If you look at 24S-hydroxycholesterol, there's a hydroxy group at both ends. It's actually a hydrophilic lipid, so it can pass right through cell membranes, whereas cholesterol, amphiphilic, one side is lipid, cannot. Now, astrocyte on the left, neuron on the right. And you see, hey, cholesterol is made. You see there's the ApoE particle, and it goes over, the neuron uses it. But now let's pay attention to how does the astrocyte make cholesterol? It goes through what is called the Block pathway, named after Conrad Block. And the penultimate sterol that it makes is desmosterol, which through one enzymatic reaction, saturation of the 24th carbon, where there's a double bond, desmosterol becomes cholesterol. So if we measure desmosterol in the periphery, it tells us it's one of the sterols that can signify hypo or hypercholesterol synthesis. But in a second, I'm going to show you something. But let's look at the neuron. It does not use the Block pathway. It uses the Can-Dutch-Russell pathway, which goes through not desmosterol, but lithosterol. Now, in the periphery, we can measure lithosterol, and it serves as a marker of cholesterol synthesis also. The only sterol marker you can use as a marker of brain cholesterol synthesis is desmosterol, because we have nice studies where if you measure desmosterol in the cerebral spinal fluid, and it obviously came out of an astrocyte, cerebral spinal fluid desmosterol level correlates very tightly with plasma desmosterol. So if you see decreased desmosterol in the plasma, that could be a signal that there is hyposynthesis of cholesterol in the brain. And whoa, here's a nice study looking at desmosterol in the CSF related to the cognitive impairment in Alzheimer's disease. And you can see in everybody, as desmosterol goes down, there is an increased incidence of cognitive impairment and Alzheimer's disease, more so in women than men. So desmosterol is an interesting biomarker that we could perhaps use to know, has there been oversuppression of cholesterol synthesis in the brain? All of the statins we use, whether they're lipophilic or hydrophilic, do get into the brain. And of course, like in the periphery, they reduce cholesterol synthesis. I wish statins could not cross the blood-brain barrier, but I don't know, with pleiotropic effects, they might be doing other things in there, because if you look at meta-analyses of statin trials, there does seem to be a reduction in AD, whether that's due to statins doing something in the brain, or just, hey, you're controlling cholesterol and reducing vascular pathology in the brain. I don't know. But the hypothesis right now is, can measuring desmosterol in the periphery be used to monitor for statin-induced oversuppression of cholesterol synthesis? My hypothesis, and I follow it right now, is if I decrease desmosterol to the 20th percentile cut point, that's it for the statin. If I have to lower ApoB, I will add one of the many other ApoB lowering drugs that do nothing to brain cholesterol. So just a nice hypothesis, but desmosterol studies are available. This is the last summary slide. There's the periphery of circulation lipoproteins. You see the ApoB particles, the ApoA1 and ApoE particles. Now let's look across that blood-brain barrier on the bottom. ApoA1 can get in. It starts swimming in the matrosome, and it starts functioning just like ApoE particles in the brain, or it jumps on an ApoE HDL, and that HDL has both ApoA1 and HD and ApoE. And they can be cleared by the neurons by LRP or LDL receptor, or they can delipidate HDL particles through the scavenger receptor. The same receptors, efflux, cholesterol efflux, exist in the brain as they do in the periphery. The same clearance of particles, the LDL receptor, exists on the brain cells. And the bottom left, if there's too much cholesterol in the brain, you can secrete 24-hydroxycholesterol right into the blood. Actually, some people think measuring 24-hydroxycholesterol in the plasma can be a marker of brain function. So, folks, I don't know how long I went. I always go too long. I always tell my friends, happy lipiding. I am at Dr. Lipid. Nobody knows Dr. Dayspring anymore. But